stop for a moment before you take your next pill. I am not asking you to stop taking your medication. I am asking you to stop just for the next few minutes and really think about something that most seniors who take Celebrex, Meloxicam, or Naproxen every day have never been clearly told. Because there is a conversation that is not happening in most doctors' offices. Not because doctors are hiding anything. Not because the information does not exist. But because a 15-minute appointment is not enough time to explain what years of research have documented about what these medications are doing inside your body beyond relieving the pain in your joints. And you deserve to know. I have spent years watching seniors take these medications faithfully every morning, every evening, every day, trusting that if there were something important they needed to know, their doctor would have told them. And most of the time, the basics are covered. Take with food. Watch for stomach upset. Let us know if anything feels off. But there is a deeper story. A story about your heart, your kidneys, your gut lining, your blood pressure, your risk of a stroke, and about a class of natural compounds available in foods you could be eating every day that work through the same anti-inflammatory pathway as these medications, at a fraction of the risk that most seniors have never been told about. Today I am going to tell you what that story is. Clearly, honestly, with the respect you deserve as someone who is managing a real and painful condition and making decisions about your health every single day. Before we go any further, if you are someone who takes these medications and you want to understand them more completely, subscribe to this channel right now. This is the kind of content we create every week, evidence-based, specific, and designed for seniors who want real answers. Hit subscribe. This conversation is going to matter to you. Now let us talk about what Celebrex, Meloxicam, and Naproxen actually are, because understanding the mechanism is what makes everything else in this video make sense. These three medications belong to a class called non-steroidal anti-inflammatory drugs, NSAIDs. They work by inhibiting enzymes called cyclooxygenase 1 and cyclooxygenase 2, COX1 and COX2, that are responsible for producing prostaglandins. Prostaglandins are the local hormonal signals that produce inflammation, sensitize pain receptors, cause fever, and also, and this is critically important, protect the lining of the stomach, regulate kidney blood flow, and support cardiovascular function. Inhibiting the cyclooxygenase pathway reduces pain and inflammation. That is the benefit that millions of seniors with arthritis depend on every day, and it is a real benefit. The pain relief is genuine. The functional improvement is genuine. For many people, these medications are the difference between a life they can live and one they cannot. But here is what the same research that validated these medications also documented. Inhibiting cyclooxygenase does not only affect the prostaglandins in your arthritic joints. It affects prostaglandins throughout your body, and the prostaglandins in other tissues, the stomach, the kidneys, the cardiovascular system. The platelets are not performing inflammatory functions. They are performing essential protective functions. And when you inhibit them, things happen that your doctor may or may not have explained in the detail you deserve. Celebrex Celebrex was specifically designed as a selective COX2 inhibitor, meaning it preferentially blocks the enzyme responsible for inflammation, while theoretically sparing the COX1 enzyme responsible for stomach lining protection. But Celebrex inhibits the COX2 pathway in blood vessels, specifically the prostacyclin production, that keeps blood vessels dilated and prevents platelets from clumping, while leaving thromboxane to the platelet compound that promotes clotting relatively less inhibited. This imbalance shifts the vascular environment toward a prothrombotic state. Research published in the New England Journal of Medicine documented that Celebrex is associated with an increased risk of cardiovascular events, including heart attack and stroke, in long-term users, particularly at higher doses. The FDA subsequently required a black box warning on all COX2 selective inhibitors, citing this cardiovascular risk. Meloxicam, sold under the brand name Mobic, is classified as a preferentially COX2 selective NSAID, but at the 15 mg dose that many seniors take, its selectivity essentially disappears and it behaves as a non-selective NSAID. Meloxicam carries the same FDA black box warning about cardiovascular events, gastrointestinal bleeding, and kidney effects as other NSAIDs in this class. Naproxen, sold under the brands Aleve and Naproxen, is a traditional non-selective NSAID that blocks both COX1 and COX2 simultaneously. Among NSAIDs, Naproxen has historically been considered to have a somewhat more favorable cardiovascular risk profile than some other non-selective NSAIDs. But it has a higher risk of gastrointestinal complications than Meloxicam or Celebrex because its COX1 inhibition more directly disrupts the prostaglandin-mediated protection of the stomach lining. Now let me be very clear about something before we go further. This video is not telling you to stop taking your medication. That decision belongs to you and your physician, and for many seniors, the benefit of pain relief that allows functional daily activity genuinely outweighs the risks that we are about to discuss. What this video is doing is ensuring that you understand those risks clearly, that you know which warning signs to watch for, and that you know about the evidence-supported natural approaches that can reduce your dependence on these medications so that you can have a more informed conversation with your prescribing physician. Informed partnership with the physician who is managing your care. That is the goal. With that foundation in place, let us talk about the 4 areas of risk that long-term NSAID use creates in seniors. The first area is the cardiovascular system. All 3 medications carry the FDA's most serious warning category, a black box warning stating that NSAIDs increase the risk of serious cardiovascular, thrombotic events, including myocardial infarction and stroke, that this risk may increase with duration of use, and that patients with cardiovascular disease or risk factors may be at greater risk. A meta-analysis published in The Lancet, one of the most rigorous cardiovascular safety analyses ever conducted on NSAIDs, examined data from more than 300 randomized controlled trials and found that all non-aspirin NSAIDs approximately doubled the risk of heart failure hospitalization compared to no NSAID use. The risk was present with all 3 medications at normal therapeutic doses, and was higher with longer duration of use. The practical implication: if you are taking any of these 3 medications and you also have high blood pressure, a prior heart attack, a history of stroke, heart failure, or significant peripheral vascular disease, you and your physician need to have a specific, explicit conversation about this cardiovascular risk and whether the benefit of continued NSAID therapy outweighs it in your individual situation. Drop a comment below right now and tell us, did your doctor specifically mention the cardiovascular risk when they prescribed your NSAID? Or was this the first time you are hearing about it? Your answer matters to this community. We read every comment. The second area is the kidneys. Prostaglandins play a critical role in regulating blood flow to the kidneys, particularly in situations of reduced cardiac output or dehydration. In older adults whose kidney function has naturally declined with age, NSAID use significantly increases the risk of acute kidney injury. Research published in the British Medical Journal found that NSAID use in adults over 65 was associated with a significantly elevated risk of acute kidney injury, with the risk highest in the first 30 days of initiation and in the setting of concurrent use of diuretics, ACE inhibitors, or ARBs. This combination, the triple whammy of NSAID plus diuretic plus ACE inhibitor or ARB, is specifically flagged in prescribing guidelines as a combination to avoid in seniors. If you are taking one of these 3 NSAIDs alongside a diuretic and a blood pressure medication, this is a specific conversation that warrants explicit attention with your prescribing physician. The third area is the gastrointestinal system. Long-term NSAID use, particularly in seniors, carries a meaningful risk of gastrointestinal ulceration, bleeding, and perforation. The risk is highest in seniors over 70, in people with a prior history of peptic ulcer disease, in people taking concurrent aspirin or corticosteroids. For seniors in one or more of these higher risk categories, the standard of care recommendation is co-prescription of a proton pump inhibitor alongside the NSAID. If you are taking Celebrex, Meloxicam, or Naproxen and you are not also taking a stomach protector, and you are over 65, this is a specific question to ask your physician at your next appointment. The warning signs of NSAID-related gastrointestinal complications that require immediate medical attention include dark, tarry stools indicating gastrointestinal bleeding, vomiting material that looks like coffee grounds indicating upper gastrointestinal bleeding, and sudden severe abdominal pain. These symptoms in anyone taking NSAIDs are emergencies that warrant same-day evaluation. The fourth area is blood pressure. NSAIDs elevate blood pressure through multiple mechanisms: sodium and water retention, reduction of vasodilatory, prostaglandins, and interference with antihypertensive medications. Studies have consistently documented that NSAID use is associated with average systolic blood pressure elevations of 3 to 5 millimeters of mercury, which in a senior whose blood pressure is already being carefully managed represents a meaningful disruption of the therapeutic control that their antihypertensive medications have achieved. The interaction between these NSAIDs and other medications that most seniors are already taking creates a prescription combination landscape that is more complex and in some cases more dangerous than any individual medication's risk profile suggests in isolation. Aspirin interaction. Many seniors take low-dose aspirin for cardiovascular protection. when naproxen is taken at the same time as aspirin. The NSAID competes with aspirin for the binding site on the COX-1 enzyme in platelets, and because naproxen occupies this site reversibly before aspirin can occupy it irreversibly, naproxen can actually block the antiplatelet effect of aspirin. Research published in the journal Clinical Pharmacology and Therapeutics documented that taking naproxen before aspirin can significantly attenuate aspirin's antiplatelet benefit. The workaround, if both must be taken, is to take aspirin first and wait at least 30 minutes before taking naproxen, a medication timing detail that most seniors taking both drugs have never been told. Warfarin and direct oral anticoagulants. Seniors taking blood thinners for atrial fibrillation or prior blood clots face a compounded bleeding risk when NSAIDs are added. NSAIDs inhibit platelet function and damage the gastrointestinal mucosa, and when combined with anticoagulant therapy, the risk of serious gastrointestinal bleeding is substantially elevated. This is one of the most clinically significant drug interactions in the senior population and one of the most underappreciated, because many seniors do not connect their over-the-counter Aleve with their prescription blood thinner. Now, and this is the part of the conversation that most seniors never reach, let us talk about what the evidence supports as the most effective natural approaches to reducing dependence on these medications. Curcumin, the active compound in turmeric, inhibits the same NF-κB pathway and COX-2 enzyme that NSAIDs target. A head-to-head randomized controlled trial published in the Journal of Medicinal Food found that curcumin produced equivalent pain reduction to ibuprofen in patients with knee osteoarthritis with significantly fewer gastrointestinal side effects. For seniors who can achieve similar pain control with curcumin alongside appropriate piperine supplementation for bioavailability, the potential to reduce or eliminate NSAID use with their physician's guidance is clinically meaningful. Omega-3 fatty acids from fish oil at doses of 2 to 4 grams of EPA and DHA daily produce anti-inflammatory effects through the resolvins and protectins pathway that reduces synovial inflammation without the cardiovascular, renal, and gastrointestinal risks of cyclooxygenase inhibition. A clinical trial published in the Annals of the Rheumatic Diseases found that patients with rheumatoid arthritis who supplemented with high-dose fish oil were significantly more likely to be able to reduce or discontinue their NSAID therapy while maintaining disease control compared to those not supplementing. Boswellia, whose boswellic acids inhibit 5-lipoxygenase, the enzyme producing the leukotriene arm of joint inflammation that NSAIDs do not address, has been studied in head-to-head trials against Celebrex. A study published in the International Journal of Medical Sciences compared standardized Boswellia extract directly to Celebrex in patients with knee osteoarthritis and found comparable pain reduction and functional improvement at 12 weeks, with a significantly more favorable side effect profile. For seniors whose primary contraindication to continued NSAID use is cardiovascular risk, Boswellia represents a specifically relevant alternative because its mechanism of action does not involve the prostacyclin thromboxane imbalance that drives NSAID cardiovascular risk. The concept of the lowest effective dose, the prescribing principle that should govern NSAID use in seniors, deserves specific discussion as a practical framework for reducing risk while maintaining benefit. The cardiovascular and renal risks of NSAIDs are dose-dependent and duration-dependent. This means that the safest use pattern is the lowest effective dose, used for the shortest duration necessary, with regular reassessment of whether the dose can be reduced as other management strategies take effect. The natural anti-inflammatory interventions: curcumin with piperine, omega-3 fatty acids, Boswellia, dietary anti-inflammatory changes. Progressive exercise require for 2 to 12 weeks of consistent use to accumulate sufficient anti-inflammatory activity to make a measurable difference. For seniors who implement these approaches alongside their NSAID therapy, and who systematically reassess with their physician whether the dose can be reduced as the natural interventions take hold, the potential to step down to a lower dose and eventually to intermittent use rather than continuous daily use is a realistic and clinically meaningful goal. The conversation to have with your physician is this: I am implementing specific dietary anti-inflammatory strategies alongside my NSAID. Can we reassess my dose in 8 to 12 weeks and discuss whether a reduction is appropriate? This is an entirely reasonable and clinically appropriate conversation for any senior to initiate. The monitoring that every senior taking long-term NSAIDs should have and that not all receive consistently includes annual kidney function tests measuring creatinine and eGFR, annual blood pressure monitoring specifically around medication changes, and periodic complete blood count to screen for chronic gastrointestinal blood loss. If you are taking any of these 3 medications, and you have not had your kidney function checked in the past year. That specific conversation with your physician is overdue, and this video has just given you the language to start it. There is a dimension of NSAID use in seniors that is almost never discussed in the clinical encounter, but that has significant implications for long-term outcomes: the phenomenon of medication-induced tolerance and the psychological dependency that develops around any effective pain management strategy. When a medication reliably reduces pain, the natural tendency is to reach for it whenever pain appears, and over time, to reach for it preemptively, before pain fully develops, as a way of maintaining the comfortable baseline that the medication creates. This pattern, which is entirely understandable and entirely human, gradually converts what was intended as an as-needed or short-term pain management tool into a continuous daily requirement. And continuous daily NSAID use is precisely the pattern associated with the highest cardiovascular, renal, and gastrointestinal risk. The research on pain psychology in chronic arthritis management is consistent on a finding that many seniors find counterintuitive. The level of pain experienced in arthritis is not a fixed property of the joint damage present. It is a perception shaped by the nervous system's amplification or modulation of the signals it receives from the joint, and the nervous system's pain amplification is significantly influenced by sleep quality, psychological stress, physical conditioning, catastrophizing tendencies, and the availability of alternative coping strategies. This does not mean arthritis pain is imagined or insignificant. It means that the same degree of joint damage produces different levels of experienced pain in different people depending on these modifying factors, and that addressing these modifying factors is a legitimate and often highly effective component of a comprehensive pain management strategy that reduces the required pharmaceutical burden. Sleep quality is among the most powerful of these modifying factors. We discussed in our arthritis bedtime video how poor sleep amplifies pain perception through its effects on central sensitization in the dorsal horn of the spinal cord. For seniors whose pain is partly driven by inadequate sleep, which is common, because arthritis pain disrupts sleep, which then amplifies arthritis pain in a self-reinforcing cycle, addressing sleep quality through the magnesium, glycinate, and tart cherry protocol, the sleep position modifications, and the reduction of the evening inflammatory foods that we have covered across this series can produce meaningful reductions in the experienced pain level without any change in the joint damage that is its ultimate source. Psychological stress is equally important. Chronic stress elevates cortisol, which promotes inflammatory cytokine production that amplifies joint inflammation while simultaneously sensitizing the pain processing pathways that determine how loudly the joint signals are perceived. Seniors managing significant life stressors, caregiver burden, financial anxiety, social isolation, health concerns beyond arthritis often find that periods of elevated stress correspond to periods of worsened arthritis pain, independent of any change in their physical activity or medication regimen. Stress management practices, the mindfulness, the social connection, the sleep optimization we discussed throughout this channel are therefore not lifestyle suggestions incidental to arthritis management. They are direct contributors to the pain experience that the medications are trying to manage. The practical synthesis of everything this video has covered is a clear set of actions that every senior taking Celebrex, Meloxicam, or Naproxen can take starting this week to improve the safety of their current medication use, reduce the dose required over time, and be a more informed participant in the medical management of their condition. Action 1. At your next physician appointment, ask specifically about your cardiovascular risk in the context of NSAID use. Bring your most recent blood pressure readings. Ask whether the combination of your NSAID with your other medications has been reviewed for the kidney, blood pressure, and bleeding interaction risks we discussed. Action 2. Ask your physician about adding a stomach-protecting proton pump inhibitor if you are over 65 and taking any of these medications without one, particularly if you take concurrent aspirin. Action 3. Request kidney function testing, creatinine, and eGFR if it has not been done in the past year. This is a simple blood test, and it provides the baseline data needed to monitor for the renal effects of long-term NSAID use. Action 4. Begin the natural anti-inflammatory interventions: curcumin with piperine before bed, fish oil with dinner, tart cherry juice before bed. Dietary reduction of the 7 inflammatory foods we discussed in our previous video, and plan a reassessment with your physician in 8 to 12 weeks to determine whether the NSAID dose can be reduced as these interventions take hold. Action 5. Begin or continue the progressive quadriceps and hip strengthening exercise program from our 7 exercises video because stronger muscles reduce the mechanical pain load that the medications are managing, and every reduction in that mechanical load is a reduction in the required pharmaceutical response. These 5 actions do not require stopping your medication. They do not require conflict with your physician. They require the kind of informed, proactive engagement with your own health management that every senior deserves to be equipped for, and that this channel exists to provide. The medication you take every day for your arthritis is not the enemy. It is a tool, a real, effective, legitimately useful tool that works best when it is used at the right dose, for the right duration. In combination with the natural interventions that reduce the underlying inflammatory load it is managing, and with the monitoring that catches the risks before they become consequences. You now have the information to ensure that is exactly how it is used. Use it well. Your body, your heart, your kidneys, your stomach, your joints is depending on you too. The complete picture that this video has been building toward is this: Celebrex, Meloxicam, and Naproxen are real medications with real benefits and real risks. The strategies to reduce dependence on these medications: curcumin with piperine, omega-3 fatty acids, boswellia, progressive joint strengthening exercise. Dietary anti-inflammatory interventions are most powerful when applied consistently, and when the underlying condition is being actively managed through all available means. The conversation your physician needs from you, and the conversation this video has been preparing you to have, is not about stopping your medication. It is about reviewing the risk-benefit calculation of your specific situation with the complete information that both sides of that calculation deserve. With your cardiovascular history on the table, with your kidney function values in view, with your gastrointestinal risk factors acknowledged, and with the natural approaches that could reduce the required medication burden as part of the management plan. You have been taking these medications faithfully. You have been trusting the process. Now you have the information to be a full partner in the conversation about whether the process is optimized for your specific situation and what changes, if any, would make it safer and more effective. That conversation starts with your physician. It starts informed, and it starts now. The senior who leaves this video with 5 specific actions, a clear understanding of the medications they take every day, and the confidence to have a more informed conversation with their physician, that senior is safer than they were before they watch. Not because they know more facts, but because knowledge translates into action, and action in healthcare compounds in its benefit across every subsequent year of life. The Arthritis series on this channel: the foods that prevent knee damage, the foods that worsen inflammation, the 7 daily exercises, the 3 movement mistakes, the bedtime anti-inflammatory protocol. And now this conversation about the medications that manage what the other interventions have not yet fully addressed is designed as an integrated whole. Each video builds on the others. The sum of the information across these videos is a complete, evidence-based, natural first arthritis management strategy that reduces the pharmaceutical burden over time while improving outcomes in every domain that arthritis affects: pain, function, joint health, cardiovascular safety, and quality of life. You deserve that complete picture. You have been receiving it one video at a time. And if this is the first video in the series you have encountered, go back and watch the others. Not because you need to watch everything before you can act on anything, but because each piece of the puzzle makes the other pieces make more sense. And the most complete picture is the one that gives your joints and your entire body the best possible chance. Celebrex, Meloxicam, Naproxen. Real drugs, real risks, real alternatives. Now you know all 3 sides of that story. Use the knowledge. If this video gave you information you needed, information that changes how you think about the medication you take every day and what you can do alongside it, please support this channel. Hit the like button right now. Subscribe if you have not already. And share this video with a senior you care about who takes these medications. Leave a comment below telling us which of the risks we discussed was the most surprising to you, or whether you are going to bring this information to your next doctor's appointment. We read every comment, and this is one of the most important conversations we can have together. Thank you so much for watching. See you in the next one.